All right, let's jump right into a really high-yield review of pain pathophysiology. We're going to follow the journey of a pain signal from start to finish. And trust me, understanding this pathway is absolutely essential, not just for your boards, but for actually diagnosing and managing your patients effectively.
So, to get us started, think about this for a second. We've all been there, right? You get a bad sunburn, and then later, something that should feel good, like a warm shower, is just agonizing. Why is that? The answer goes way beyond because it hurts. It's all about a core process called sensitization, and we're going to break down exactly what that means.
So here's our game plan. We're going to follow this journey in 5 main parts. First, we'll talk about what pain even is, the body's alarm system. Then, we'll meet the specific nerves that act as messengers. After that, we'll get into what happens when that alarm malfunctions. From there, we'll trace the signal's path up the highway to the brain. And finally, we'll look at how the brain itself is the ultimate control center.
Okay, part 1. Pain as the body's alarm. I mean, this is no surprise to any of us, right? Pain is the #1 reason people go to see a doctor. It's this fundamental primal signal that something is wrong, and our job is to figure out what it means and how to fix it.
So, what is pain, really? Well, at its core, it's this unpleasant sensation. But here's the crucial part. It has a dual nature. It's not just a physical sensation, the burning, stabbing, or aching part. It's also an emotional experience. Words like terrifying or nauseating come to mind. And knowing this is so important, because when your patient is describing their pain, they're giving you clues about both what's happening physically and how they're emotionally processing it.
So let's move on to part 2 and see how this signal gets started. How does a stimulus, out in the periphery, get turned into this really complex experience? Well, it all begins with the messengers, these highly specialized nerves that carry the pain signal.
Now take a look at this. A peripheral nerve isn't just one type of wire. It's more like a bundled cable with all sorts of different fibers inside. You've got these big, thick A-beta fibers. But for pain, we're really focused on the little guys, the smaller A-delta and C fibers. These are our primary pain receptors, our nociceptors.
Okay, this table right here, this is classic, super high-yield stuff for your exams. The big, fast A-beta fibers, they do light touch. They're not supposed to hurt. The pain signals are carried by the other two. Think of the A-delta fibers as the first alert. They're myelinated, so they're pretty fast, and they give you that initial, sharp, ouch kind of pain. The C fibers, on the other hand, are like the lingering status report. They're unmyelinated, they're slow, and they're responsible for that dull, throbbing, aching second pain that comes later. All right, part 3. What happens when this alarm system goes haywire? This gets us right back to that sunburn question. The mechanism is called sensitization, and a great way to think about it is like a faulty volume knob on your pain system that's gotten stuck on max.
So here's the deal with sensitization. After there's some kind of tissue damage or inflammation, the nociceptors become way more responsive. 2 things happen. Their activation threshold drops way down, and they fire a lot more frequently. And what does this look like in the clinic? You get hyperalgesia, where a painful poke feels way more painful. And you get allodynia, which is when something that shouldn't hurt at all, like the touch of a bedsheet, causes real pain.
And this sensitization can happen in 2 main places. You've got peripheral sensitization, which is right there at the site of the injury. But if the pain is strong enough and lasts long enough, you can get central sensitization. That's when the neurons in the spinal cord itself become hyperexcitable. This distinction is absolutely critical for understanding and treating chronic pain syndromes. Let's make this real. Picture this. Your patient, a 68-year-old with post-herpetic neuralgia, that lingering pain from shingles, tells you that even the light touch of his shirt is unbearable. That is a textbook example of allodynia. And it tells you that you're not just dealing with the initial injury anymore, you're dealing with a nervous system that has fundamentally rewired itself.
And this diagram shows you why this happens on a biochemical level. When tissue gets damaged, cells release this chemical cocktail. It's literally called an inflammatory soup. All these mediators, like bradykinin and prostaglandins, they don't just activate the pain nerves, they marinate them, which lowers their firing threshold and turns up that volume knob. This is peripheral sensitization in action.
Okay, so the signal's been generated, the volume is cranked up. Now what? Let's move to part 4 and follow that signal as it travels up the highway to the brain.
This right here is the main superhighway for pain, the spinothalamic tract. Let's trace it. The first nerve comes in and synapses in the spinal cord's dorsal horn. Then, the second nerve immediately crosses to the other side and shoots all the way up to the thalamus, the brain's big relay station.
From the thalamus, a third neuron sends the signal out to the cortex, specifically the somatosensory cortex, and that's where we get the conscious perception of, ouch, that hurts and it's on my left foot.
Now, this pathway beautifully explains a classic clinical concept, referred pain. Why does a heart attack cause pain in the left arm? Well, as you can see here, the pain fibers from our internal organs, the viscera, they actually converge on the exact same spinal neurons as the fibers from our skin. The brain, which gets way more information from the skin day to day, gets its wires crossed and interprets the signal from the heart as if it's coming from the arm.
And that brings us to our final, and maybe the most fascinating part of the story. The brain is not just sitting at the end of the line passively receiving these signals. Nope, it's an active control center that can powerfully change or modulate the pain signals it receives.
So check this out. On the left, you see the bottom-up signal we just talked about going to the brain. But look at the image on the right. That shows a top-down pathway that originates in the brain and travels down to the spinal cord. It acts like a gatekeeper. This descending system can either inhibit the pain signal, basically telling it to quiet down, or it can facilitate it, telling it to get even louder. And this quote just nails it. It explains why things like our expectations, our beliefs, our mood have such a huge effect on how much pain we feel. It is not all in your head. These psychological states are literally engaging these very real, physical brain circuits that control the pain gate down in the spinal cord. And we can actually see this happen. This is an fMRI scan showing what the brain is doing during placebo-induced pain relief. When a person believes they're getting a painkiller, that belief alone is enough to light up this whole descending network, areas like the prefrontal cortex and the periaqueductal gray. This is the physiological proof that the brain is actively managing its own experience of pain.
So, let's wrap this all up. What are the key takeaways? 1. Pain is always both sensory and emotional. 2. If a patient's pain seems totally out of proportion, you have to suspect sensitization. Look for allodynia and hyperalgesia. 3. Listen to your patient's words. If they say burning or electric, that's the language of neuropathic pain. And finally, and maybe most importantly, remember that psychological factors aren't just fluff. They activate real, powerful brain circuits that control pain.
So I'll leave you with a question to chew on. Now that you have this whole framework, from the tiny nerve fiber in the skin all the way up to the brain's descending control centers, how is that going to change the way you listen to and assess your very next patient who comes to you in pain?